Welcome to New Money. I'm Bryan. This evening we're focusing on the healthcare industry. Over the last few months, South Africa's decision about national health was passed by the National Council of Provinces, excluding the Western Cape, who voted in favour. Previously, Parliament had passed the bill despite huge opposition from many players in the medical industry. It's now waiting for final signature from the President's office. And joining me this evening is Roseanne Harris. She's Head of Policy and Regulatory Affairs at Discovery Health. Roseanne, good to have you on the show, and thank you for joining me.
Thank you for the invitation.
Roseanne, let's just ask this question. Is it likely the President is going to sign this bill without really consulting and getting all the feedback from the industry?
So the consultation process is part of the parliamentary processes, and those have taken place, as you said. I mean, back in early December, the National Council of Provinces has now signed off on the bill. The final step is for the President to sign the bill. And his constitutional obligation, as I understand it, is to make sure that the bill is not in conflict with any constitutional provisions. And that process, as we understand from the Office of the Presidency, is currently underway. So if there are any concerns around whether the bill is constitutional, then the President needs to send it back to the National Assembly for consideration of those challenges.
There's a big difference between constitutional and practical.
Of course.
I mean, the industries are commenting on the practicalities of NHI, not the constitutional. So I mean, if he signs it off, where to from here?
So, I mean, you're quite right that there's a big difference between practicalities and constitutional issues, and the stage the bill is at now is about consideration for constitutional issues, and there are actually quite a few constitutional challenges with the bill, which is going to make it very difficult to see it proceeding without there being some challenge. Either it gets amended through the government's legislative processes, or it's going to end up going to the Constitutional Court, which is not ideal, because, as you say, there are practical issues here, and what we really need is to have a health system which is serving the interests of everyone in South Africa. And I think you have an industry in South Africa that is wanting to contribute and participate in doing just that. That's why you hear everyone saying that there is a strong commitment to universal health coverage, and there's a lot of ideas in terms of how that can work in a much more practical way than the single fund model that is, as you say, not practical and also arguably not affordable for South Africa. What we need is a collaborative, incremental approach to actually reaching people and getting healthcare access for everyone.
Roseanne, we did have some collaboration on COVID.
We did.
I mean, it seemed to be working, and we did a fantastic job. Now, let's just talk about it. So we talk about constitutional. We also we've got an election. Is it popular? Is it a popular process to sign the bill off? So I'm saying if it is signed off in its current form, it'll then go to the Constitutional Court.
In all likelihood, yes, and the tragedy is that if it's signed off in its current form, it's not really going to have any effect because it's not practical. So the problem then is that you're going to have a piece of legislation which actually doesn't make a difference in terms of people accessing healthcare, and we're going to be stuck with the situation of the current inequalities perpetuating, and all of these initiatives which could be implemented if there was a more collaborative approach taken with some small amendments to the bill to accommodate those, then not being able to be implemented, and that would be tragic. And I think, Bryan, important to stress that even if the bill is passed in its current form, it doesn't make any tax changes. Those tax changes only take effect once the National Treasury introduces a money bill, and that hasn't happened yet. So the bill in its current form doesn't have any tax effect either.
Well, when you say tax effect, I mean, each one of us gets a tax credit. And if you're under 65, it's a lot less than if you're over 65. I mean, the talk is that possibly in the budget, they're actually going to do away with that tax credit. Any comments you'd like to make on that?
Well, I
I
mean,
know it's speculation.
it is speculation, and it seems to happen every time there's a budget, that there's speculation around the tax credits. The Health Market Inquiry, which published its report back in 2019, recommended a restructure of the tax credits rather than doing away with the tax credits, because they're very important for quite a significant segment of the medical scheme population in enabling them to stay on their cover, to continue to afford their cover. For low-income households, the tax credit translates to about 1,220 Rand a month for a family of 4. That's significant in terms of being able to stay on cover. And what doing away with that in its entirety would mean is that those households would then no longer be able to afford medical scheme cover, and they would then be dependent on public sector facilities, which is just going to exacerbate the pressure and the burden on public facilities. So it's not in anyone's interest for that to happen at the moment at all, until there is a public sector that is able to accommodate and deliver those services.
I'm going to sneak in a question which it may be a little bit unfair, but we've got a situation now when you look at the provincial hospitals, the waiting periods, the difficulties, and on the other hand, we hear about so many doctors who can't find posts. So, I mean, it doesn't make any. I can't get my hands around that.
Yeah, it really is. I mean, as you say, it's a contradiction that we have such a shortage of healthcare professionals serving our population. When you compare our stats to other countries, even of similar economic standing to us, let alone the OECD countries, our ratio of doctors to the population is way below our comparative countries, and so the fact that we have healthcare professionals that could be serving our population sitting at home, it is tragic, and this is why we need to be working together and actually getting our health system on its feet and working well for everyone.
Okay, so now let's go one step ahead. What about low-cost schemes? Why are we not getting approval for low-cost schemes to be introduced by different medical aids?
Yeah, so I think it would be really beneficial if the medical schemes were able to offer the kind of primary care options that some of the insurers are able to offer through these exemptions, which ironically have been granted to them by the Council for Medical Schemes, but those exemptions haven't actually been granted to the medical schemes themselves, because the medical scheme environment is quite a protective environment in terms of the regulatory framework, and so for those people to be able to purchase that cover inside the protections of the medical scheme environment, let alone having access to the tax credit, would be very much in their interests. And it's really tragic that here we are 7 years down the track and those options have not yet been approved on medical schemes.
And let's just talk about the council, because the council made recommendations to the medical schemes to limit the increases for 2024 to 5.7%. Obviously, it was not possible. I mean, you do the numbers, people don't realize you pay a medical aid a certain amount of money. They don't realize that there's a company administering the medical aid, and the medical aid itself has to be solvent and have those solvency margins. And not only the medical aid, each plan, I understand, has to have its solvency margins. And in some cases, medical schemes were increased to even over 10, 11%. I mean, going forward, if you take that, if you take the rule of 72, you being an actuary would know very simply, if inflation is at 9%, medical aid inflation is 9%, then in 8 years' time, your medical aid is going to be double. So someone retiring now at 65, in 8 years is going to be paying double, and in 16 years at 81 is going to be paying double again. For 4 times what they're going to be paying today. Now, it's going to be absolutely unaffordable. How are elderly people going to fund for medical aid in retirement? The earnings come to an end. Here you've got, now you've got, while you're working, you've got a bit more earnings, you eke a bit more away. At retirement, you've got to rely on your capital growing, beating inflation, but medical aid inflation is way above any other CPI number we were talking about.
Yeah, you're absolutely right. I mean, and this issue of medical inflation being above general inflation, it's a global challenge because we have these pressures of, new technology, aging population, more access to more expensive treatment and so forth. And these are huge pressures on the risk pools of medical schemes. So we need to look at the way in which these innovative approaches can actually be not just giving people more access to healthcare, but also addressing affordability constraints. One of the challenges we have in the medical scheme environment is that the regulatory framework kind of exacerbates the problem because it makes it very easy for people to wait until they're sick to access the medical scheme environment, which remember is a community pool. So it relies on the healthy cross-subsidizing the sick and the young cross-subsidizing the old, and so you need to have the young and healthy in that risk pool, and so of course as we look at economic pressures, particularly on young families, the challenge of being able to afford a medical scheme cover is there, and that's why you'll see a lot of innovative approaches in the way that benefits are being designed to attract the young and healthy into the system. But some of the proposals, I mean, that's why the NHI framework is really valuable in terms of creating an environment where everybody is participating in a risk pool, and so it's not a case of saying that we need to move away from an NHI environment altogether. What we need is something that's practical and workable that's going to also help us to address the inflationary pressures in the medical scheme environment as well, and that's been the real push of inputs that have been coming from the private sector. I mean, broadly, not just from the private health sector, but from organised business as well.
Now, Roseanne, when you talk about cross-subsidisation, I think about the Lloyd's Coffee House, how insurance always started, the few, the many supporting the few who were in shipping.
Yeah.
So let me just talk about cross-subsidisation. Younger people, and I've even got an email from a younger person, which we'll deal with in the next segment, ask, what should I be doing? The younger people are looking very differently at health costs. So that means the cross-subsidization of that pool is aging.
Yeah.
How does one get around that?
So you're right. I mean, when you look at, and you spoke earlier about how the medical schemes have to kind of balance the books, right? You've got the medical scheme contributions coming in to the risk pool, and you've got the claim payments going out, and the cost of treatment is increasing because we need to be obviously paying the doctors and the nurses more to keep pace with inflation. But actually, the number of services that are required is also increasing because the population is getting older, and that's why having a system which covers the population as a whole then creates those cross subsidies that are important. I mean, when we look at our population here in South Africa, we have the benefit of a population that is not aging. We're not plagued by the same problems that you see in countries in Europe, for example, where the overall population is aging. If we can, for example, in the broader economic sense, get more people into the workforce, create a more economically active population, that will have a knock-on effect in terms of then having risk pools that are more sustainable, that can then, as you say, carry those cross subsidies. But we do need to have that broad focus of how do we get the whole system to work better, to make sure that we're preserving affordability into the future.
We haven't even spoken about cost, but when we come back, we're going to take a short break. I'm going to ask Roseanne, and the most important part exactly is, if the NHI comes in, is that the end of private medical care? Stay tuned, I'll be back shortly.